Dear colleagues, welcome to this second webinar on surgery in patients with hemophilia. Today we will going to discuss on how to manage surgery in patients with inhibitors. And this webinar is organized in the frame of the EHEAD e-learning program, and it's my great pleasure to welcome a very distinguished hemophilia expert and friend, Professor Elisa Mancuso, from Milan Humanitas University and Research Hospital. Elisa, welcome.
Thank you, Yesim. It's a pleasure to be here with you today.
Thank you so much to be here. So we will discuss together how we manage surgery in patients with hemophilia, and without wasting any time, let's get started. Elisa, please, can you tell us how do you manage and organize surgery in your patients with inhibitors?
Thank you, Yesim. So yes, it's my pleasure today to give an overview on which are the best practices for managing surgery in patients with hemophilia and inhibitors, which represent a challenging group of patients, even though nowadays we have new possibilities to manage such patients. So the keys, let's say that the key figure to manage successfully surgery in hemophilia patients overall, and especially in patients with inhibitors, are represented in this slide. As you can see, we are talking about a teamwork, and we always mention that a multidisciplinary approach is the best way to manage patients with hemophilia, and this is particularly true in the management of surgery. What is important for surgery is a good organization and, if possible, a planning of what is needed to perform a successful surgery. Here you can see that the hematologist is put in the middle of the figure, not because of the importance, but because we have to acknowledge that most of time the hematologist has a role of coordination of the whole team. However, this team is really important in all its parts, and we have the surgery team, including the surgeon, the anesthesiology, and the nurses. We know that we need the collaboration with the pharmacist, because without the drug, surgery is even not possible. And of course, we need a lab, and we will see that the special role of the lab in this challenging group of patients. And then if we think about the most common surgery type in hemophilia patients, which is orthopedic surgery, we cannot forget the rehabilitation team, because patients do need to be rehabilitated after the surgery. But we have not to forget also that the patient is an active part of this team. He or she should be aware of what we are going to plan and how we organize the surgery, because his or her collaboration is also very important. There are some questions that may help us to plan and organize everything in a good way. And these questions pertain the peculiarity, or let's say the specificity of the surgery that we are going to perform. So which is the bleeding risk associated with the surgery, and which is the level of hemostasis that we need to prevent any bleeding complication, or let's say to make this surgery an eventful situation. In particular, but this is true for all patients with hemophilia. If we think about inhibitor patients, what is really important is to have good knowledge and information about the inhibitor situation of the patient. What I want to say is that we need to know which is the current titer. So the titer at the moment at the time of surgery, but also which is the potential anamnestic response for that given patient, because we all know that we can have patients that today has less than 5 Bethesda units. So let's say that at the time of surgery, they have a low titer inhibitor, but the potential of that inhibitor upon re-exposure to the antigen, that can be factor 8 or factor 9, is to have a high response, going far beyond the 5 Bethesda units, and these make a difference. And we will see it in a moment. The other point is if we can and in which way we can monitor in the lab such patients, their hemostasis. This is a bit different from patients without inhibitors, where we can just monitor levels of factor 8, factor 9. In inhibitor patients, still we are not that defined, I would say, as non-inhibitor, but we can do something different also. And of course, we should plan for how long we need therapy for those patients to cover all the period of surgery and post-surgery until wound healing. And another good evaluation that will help us a lot to perform a successful surgery is to also consider all the possible complications. Because in inhibitor patients, we have to acknowledge that managing bleeding complication is a little bit more difficult as compared with non-inhibitor patients. So we should include in our planning and organization the possibility to have excessive bleeding, and so to be proactive and reactive against this situation. Sometimes we have also to acknowledge that in some patients, especially those with a very severe bleeding phenotype, excessive bleeding can lead to death. So we have to consider very carefully the type of surgery and maybe also the technique that the surgeon will use in order to minimize any risk related to that. We also have to acknowledge that surgery per se is a risk factor for thromboembolic events. And the use of bypassing agents may impinge upon this risk, even increasing that. So we have to take into account also this possible complication. And the fact that inhibitor patients may bleed a little bit more than non-inhibitor patients can be the cause of some postoperative complication as infections, especially when we think about orthopedic surgery. We know from the literature that the higher chance of bleeding complication is related to a higher rate of infectious complication on the arthroplasty. But what is the bleeding risk? Patients with inhibitors generally do not bleed more than non-inhibitors. The point is that when a bleeding complication occurs, it's more difficult to manage that bleeding complication. So the management of a bleeding that starts is longer in time and sometimes require more intensive treatment, and in some cases also different therapeutic approach because a non-response to a single agent. So in that, considering that, it is also to and we have to acknowledge that inhibitor patients are those presenting more arthropathy, at least in the old generation. Hopefully in the future it will not be like that. But we know that nowadays our adult patients with inhibitors are those with the worst stage of arthropathy, so they need more surgery. And also in the presence of a bleeding complication for surgery, the management can be a little bit more complicated. That's why we have to be prepared with many alternatives in order also to rescue maybe a non-response or a bad response to some hemostatic agents. So what is important is also to organize and to have in mind what are the good way to organize everything to lower the possibility to a complication. We already mentioned about the inhibitor theta, and we will go into a detail in a minute. But of course, what is very important is that surgery in such patients should be performed in an expert environment, meaning that hemophilia treatment center with drug available and expertise available, not only in the hematological part, but also in the surgical part, should be the best way to organize everything. And of course, we need an hospital with an intensive care department because some of those patients may bleed really in a bad way, so we need support from the intensive care. And of course, sometimes we also need to use continuous infusion to treat those patients in order to ensure a good hemostasis. And so we need also some expertise in the management of such delivery method for drugs. Another, maybe something that may appear as secondary, but it is not, is to consider all the comorbidities and also the concomitant medication of our patients, because we need to minimize at best what are the situations that may impinge upon bleeding complications that sometimes are not really related to hemophilia. For instance, the use of some antidepressive drugs reducing the serotonin uptake. We know that this may impinge upon platelet function as well as non-steroidal anti-inflammatory drugs. So the discussion with the team starts with the anesthesiology. And one of the big questions is how to perform anesthesia in these patients. We all know that in patients with a high risk of bleeding, it's better to avoid neuraxial anesthesia in order to minimize also the risk of local hematomas in the spine. So general anesthesia sometimes is preferable, and we can, after a good coverage with hemostatic agent, we can allow for peripheral anesthetic blocks, which are very effective and may also help to control the pain after the surgery, in order also to minimize the use of non-steroidal anti-inflammatory drug for pain control. So what about the management of the bleeding complication, or at least how to ensure a good hemostasis for surgery? We have to distinguish patients according to their inhibitor titer at time of surgery, and also consider the type of surgery. So we all know that if the inhibitor titer overwhelms 5 Bethesda units, we cannot use replacement therapy because we would need too high dosage or even impossible dosage to be administered to neutralize the inhibitor potential. So we have, when we have an inhibitor titer above 5, we have to go for bypassing agents, meaning recombinant 7A or activated prothrombin complex concentrate, APCC. And both of those drugs have been used since years to cover surgery successfully. And it depends also on the expertise of the hematologist, and which is, let's say, the habit of the hematologist to use one more than another, and the response of the patient. So there is no first line, second line. In some cases, recombinant 7A is somehow more manageable, just because we can administer it every 2-3 hours, so we can adjust to it's a little bit more flexible than APCC, for which we have let's say a caution or a warning related to the per day dosing that should not overwhelm 200 units per kilo per day. So according to these difference and limitation, and also to according to the response of the single patient, we can choose either one or the other. Also reminding that recombinant 7A should be repeated at 2-3 hours intervals for at least the first week of treatment, while APCC can be delivered every 8 to 10 hours according to the response and also to the type of surgery that we are going to do. And here you can see that in the postoperative period, then we can de-escalate dosages and the infusion while we are going to ensure wound healing if there is no bleeding complication. In the case of a patient with low persistent inhibitor titer, having always below 5 Bethesda units, also upon re-exposure, we can use factor 8, factor 9 replacement therapy, because we can monitor, we can measure, and we can ensure the levels that we want to ensure, as we do in non-inhibitor patients. We know that in case of the presence of low titer inhibitor, it might be useful to increase a little bit the dose or to narrow the intervals between injection in order to cover completely the neutralizing activity of inhibitor and then to ensure hemostatic level. In very rare cases, we can use immunoabsorption in order to lower very fast the inhibitor titer, and then to use replacement therapy even in the presence of high titer inhibitor when there is no response to both bypassing agents. Just to note that even though there is available porcine recombinant factor VIII, which is used in acquired hemophilia, this is not indicated for patients with congenital hemophilia because there are no studies and no data supporting its use in this setting. So for bypassing agents, we know that the efficacy rate in the surgical setting is rather high. We have to acknowledge that there are differences. As I already mentioned, the interval in the administration is pretty much different, and it's more challenging for recombinant 7A. However, this also gives, in some cases, more flexibility at variance with APCC. Even though there is the possibility to increase thromboembolic risk, data from the literature and experience tell us that the risk is really low if we properly use those drugs in the label dosing. And the other point is that the other difference is that we have one is a recombinant product and the other is a plasma derived, and the cost is let's say comparable for both, but for sure the use of a recombinant product with a small volume as recombinant 7A can be also an advantage in some setting as compared with APCC. The use of replacement therapy is limited at patients with low inhibitor titer, and we have to take into account that for patients with high response, since we are exposing them back again to the antigen, this may increase a iatrogenic anamnestic response. So we have to be aware that a patient starting with 2 Bethesda units with the potential of having 100 Bethesda units will go for a high response in few days after the surgery. And also in patients with hemophilia B with inhibitors with previous allergic reaction, the re-exposure to factor IX can be complicated with that. So this should be taken into account when considering also the post-operative period and the risk of new bleeding complication after surgery. Antifibrinolytics are always a good adjuvant therapy in the setting of surgery. We know that for replacement therapy, but this is true also for bypassing agents. There are reports of very good efficacy in combination with recombinant 7A. Sometimes there is a warning of the combination of antifibrinolytics with APCC. For a long time, we consider that to be at risk of increasing the thrombotic complications. And indeed, this is not in label. However, there are some reports of a safe combination of APCC and tranexamic acid. I would say in a control setting, this is possible without overwhelming the recommended doses. So which kind of drug to use? This is really related to the type of surgery and to the situation of a patient. I would say that for a surgery without a very high bleeding risk and the patient with a high anamnestic response in inhibitor titer, going for bypassing agents may be safer for a patient for whom we know that they are good responders to bypassing agents, because if we stimulate an amnestic response and after surgery for any reason that patient will have a major bleeding, we have no chance to use replacement therapy. On the other side, if we have a patient who's undergoing a very high risk surgery in terms of bleeding complication, even though there is this patient is a high responder, but at the time of surgery he has a low titer, is a very good way to manage this surgery could be to use replacement therapy, because we can calculate exactly which is the dose to neutralize the inhibitor neutralizing activity, and to ensure and measure which is the clinical response to replacement therapy. In this case, if we think about using replacement therapy in patients with inhibitors, there is a way to somehow control for some days and to delay a little bit the anamnestic response that usually occur after 5 days. The good way to benefit from replacement therapy is to use continuous infusion, because for the initial day, the first 48 to 72 hours after surgery is a way to maintain, neutralize the inhibitor, and to maintain hemostatic control without peak and trough, but maintaining a steady state, knowing and monitoring the fact that after 5 to 7 days, we will have an amnestic response, and so we will lose the response to replacement and we need to switch to bypassing. But this will occur far enough from the surgery, and so in a way to maintain a good safety and protect our patients for severe bleeding, from severe bleeding complications. Of course, there should be a personalized treatment plan for elective surgery. And is this possible? We always do that for non-inhibitor patients because we know which is the PK response to replacement therapy. For patients with inhibitors, this can be a little bit more complicated, but there are lab tools that may allow us to understand which is the response to bypassing agents. These are data produced from Professor Dargaud in Lyon, and they prove to be really useful to guide clinicians on which bypassing agent to use, and also at which doses to perform surgery. There is a good correlation with thrombin generation assay to see which is the performance of a bypassing agent. However, we have to acknowledge that, and here you can see that if you choose the bypassing agent based on such laboratory experiment or evidence, this is a good way to perform safely the surgery. However, we have to acknowledge that the access to such lab tools is not universal. So that's why also it's useful to have an expert hemophilia treatment center also with a lab setting for the management of such patients, because this particularly lab tool may be an helpful tool to be used to guide clinician in the management of patients. And also, the WFH recommend this that clinical monitoring is really important. So it's the first way to monitor patients, but if possible to have this laboratory tool, this can be used to guide, even though they are not standardized for this use and they are not widely available everywhere. With this, I thank you for your attention, and I hand over to Professor Dargaud to continue with the case report on surgery in patients with hemophilia and inhibitors.